So for our second Saskatchewan Spotlight segment, we're going to have Dr. Jeffrey Irvine, who's a family physician in Loren, talk about the community physician perspective. Loren Regier, program coordinator of RxFiles, our academic detailing service, talk about how RxFiles connects with prescribers. And then Bob Parker, who's the program manager of the Antimicrobial Stewardship program at Regina Qu'Appelle, talk about coordinating an antimicrobial stewardship program. And after that, we'll have our much-promised interview panel. So Jeff, Loren, and Bob, can you come up? And I think, Jeff, it's all set up for you. So, Dr. Jeffrey Irvine.
Yeah, thanks. Yeah, so I'm a generalist physician in northern Saskatchewan. Generalist meaning that I do all aspects of primary care. So I have inpatient medicine, outpatient, there's emergency services, there's obstetrical services. And so I'm also the co-chair of the Antimicrobial Stewardship Committee in the Churchill River Health Region, so the health region in the northeastern part of the province. But I'm going to take a few minutes now to talk about the community physician aspects that we need to think about when engaging physicians at that community level. And I realize that there's lots of different physicians in Saskatchewan and that we're going to be discussing and talking about. Mostly going to be talking about community physicians in this respect. So mostly what we're going to talk about in the talk is why physicians aren't more engaged and therefore how we engage them. And I realize this is going to be oversimplified, but in the why aspect of it, really, I think breaks down to two different aspects. One is that they're just not interested. Secondly, they just have a lack of time. Everybody's busy. But we're going to talk about these a little bit more and maybe try to figure out some things of how to address these a little bit further. So let's talk a little bit about the lack of interest. And really, when I say lack of interest, I don't think it's actually true lack of interest. I think people know that it's important. They see the graphs that antimicrobial resistance is increasing. They've been shown them. They know that it's an issue. I think rather that they think it's not actually them that's causing the problem. They think that they're doing an actually pretty good job, that maybe instead of them working on antimicrobial resistance themselves, it's other people doing it. So they think that, oh, I saw somebody with an upper respiratory tract infection today. I didn't prescribe antibiotics. Boy, I'm doing a great advocacy job for antimicrobial resistance programs. But I think there's a few things that we can talk about and discuss with them to try to figure out a little bit more in terms of addressing these type of thinking or thought processes. And one of them is actually resistance patterns. And in particular, we're going to talk about this, other people are going to talk about this a little bit further on too and tomorrow as well. But really addressing that aspect of it, of resistance patterns locally, is so interesting for physicians to know. You could provide them provincial data or national data, and it's better than nothing. But if you actually get regional data, the more localized it is, the more interesting it is to physicians and get them starting to talk about and think about the antimicrobial resistance. And then further to that is the actual antibiotic usage, because I find that when I show physicians the antimicrobial resistance patterns, or the antibiograms, when I show them this, they think, oh yeah, that's pretty good. There's a resistance. Okay, interesting. But I think a lot of them think, oh, I think I'm doing a pretty good job at that antibiogram. I think I followed that pretty good. But when we actually look at what they're actually prescribing, if we follow that through EMR data and show them actually you're using this antibacterial quite a bit more than you think, then that links that much further. And it's a little bit of work to identify that and to focus on that at such a small level, but it makes it so much more interesting and applicable to the individual physicians themselves. Other thing that I find is working fairly well is just small discussions around the patient or at the hospital itself. One example is that in Loren right now we're working on the IV to PO antibiotic switch that was being discussed previously. But even though the study's results aren't out yet, we're not even finished the study itself, but we're finding that there's more discussion around the switching processes. So we've been educating the students and the residents about it, and at first it was just the antimicrobial committee that was talking about this more, and now we're finding that this other physicians and other staff members are starting to discuss it a little bit more as well. So just having that conversation in the open and talking about that a little bit more gets people interested in what's going on. And the final thing that I think is very interesting and physicians find very interesting is the actual peer-to-peer comparison of it. And again, we'll talk a little bit more about this, especially tomorrow, but having that comparison to other people really gets you thinking inside a little bit more about what's happening. And it's been shown across other areas, and everybody is very aware of that, that across other, not just antimicrobial aspects, but in other healthcare regions and aspects of healthcare, that it is a pretty useful data tool to decrease antimicrobial resistance. And this study in JAMA shows this from last year. But I guess we've got to be careful that it's just not a tool to just use all the time. There's a couple of things for it to think about at least. Because, for example, this other study in JAMA of internal med this year showed that it actually maybe not as good. This particular study didn't think it was quite as good for decreasing antimicrobial usage. It showed across sort of 2 years of actual implementation of this study that didn't really change things too much. But I bring this up not to discuss the utility of peer-to-peer comparisons, but more the fact that it's an interesting thing to think about for physicians, and they like to talk about this and try to compare themselves to others with it at least. Other things that I find is useful for things are just quick topics to think about with physicians, and I find that even just when I see somebody in the hallway, just to talk about things a little bit, and it's not like on the fat cats are pouncing on them saying, we're going to talk about antimicrobial resistance right now, but just things that I find interesting that I think they think are interesting. So, for example, in patient order sets, and if somebody is admitted with pneumonia, they may have used the patient order set. I just chat with them sort of off-key, like not an actual meeting, just like, what do you think about this order set? What did you use for antimicrobials? Do you think it's appropriate to put it in this order set? Why is it in there? Can you provide me some feedback on this order set? And I find that type of feedback is much more useful. I receive much better feedback with it compared to just emailing out to the group saying, please review this and send it back to me. Other pertinent topics that I find right now for at least my physician group that I'm working with is things like strep pharyngitis and whether cultures are required, with some of the studies saying that maybe we shouldn't be treating anybody regardless of signs and symptoms, even if we think it's a bacterial aspect of it. There's lots of different discussions going around with that right now, and a lot of physicians are interested in talking about those type of things. And of course, all these are very specific to the area that you're in and the type of physicians that you're in, but having these little topics that you could talk about, especially if they're around little cases, then I find it's very interesting too. Other ones that my physicians are interested in that I find is the H. pylori aspect of it and whether we should be treating H. pylori. If they're asymptomatic, should we treat it? Should we be screening everybody? If we find it, should we treat it? What medications do we use? If we do a test of cure, is it needed at all? Or days of antibiotic usage, how long do we treat for? Do we do 3 versus 5 and the new data that's coming around with that? And that's all those things that physicians like to talk about, and it's interesting without actually setting up a meeting and saying, let's talk about antimicrobial resistance. Now, once we have them interested a little bit more, we have to start maybe trying to get them on board a little bit in terms of actual meeting with them if they want to be part of the program or trying to set up something with antimicrobial resistance patterns. Now, everybody's busy. I, for example, have my scheduled patients set up for me months in advance, like a month or in advance at least. And so finding time around that to get a meeting in makes it a little bit difficult. As the organizers of this conference know, I don't really have time to do stuff, and I think I only came, 1 or 2 times? But if you know your schedule of meetings far enough in advance, it makes it much more likely that a physician's actually going to attend. Because they're not going to be canceling patients just to come for an antimicrobial resistance meeting. Regardless of how passionate they are about it, it's difficult to cancel patients. And so there's other ways that we're trying to get around that now. One is maybe doing meetings at lunch hour instead. Obviously, you have to provide them a little food for some incentive to get there, but that can be useful. Nighttime meetings are not very happy. They're not really happy to get there, but a lot of our meetings now are happening at that time just because that's when physicians are more available. The patient load is done for the day, and they're more available with it, which brings up some discussions about being reimbursed for that time, that they're not going to be seeing patients outside of patient hours, or maybe thinking about some altered payment plans with that too, and some things to think about in terms of getting physicians involved. So as you can tell, there's engaging physicians in antimicrobial stewardship is multifaceted, but can involve patient comparison and patient order sets and maybe antibiograms, but you need to make it easy basically for physicians to be involved. If it's difficult, it's just not going to happen. And so in discussing this, you could hopefully engage a few physicians to be more appropriate prescribers, but maybe even be involved in their own antimicrobial stewardship programs themselves. So there's a few points to at least continue the discussion. We'll have some more discussion later on as well, but thanks for coming.
All right. My name is Loren Regier. I'm with the RxFiles. I'm a pharmacist at Saskatchewan City Hospital. Been working with the RxFiles now for 20 years, and so that's been a big part of my life. I realized that I missed a really good opportunity to get a few smiles by not including the picture of my pet, because he had a couple of cats. Everybody kind of lightened up there and was enjoying the moment. Well, if you go to our drug comparison charts, antibiotics, and look and search for the dog bite section, you will find my dog together with Brent's cat, Brent, the pharmacist I work with, and you can see what little coconut a nice little Shih Tzu looks like. No conflicts of interest with the industry. We have a grant from Saskatchewan Health to provide academic detailing in the province. We get some revenue from sale of printed and digital materials outside the province. We try to give away as much as we can in the province and sell a bit on a not-for-profit, not-for-loss basis outside the province. I had at one point a to-read someday file. I don't know if you have those. I don't have one anymore. Can anybody guess why? It was not a file I got to. It was just a file that eventually I chucked stuff out of. And part of the academic detailing that we do, which involves a visit to a prescriber, we're focused on drug therapy, to a prescriber to talk about drug therapy decision-making. And you could just send some stuff out in paper, and that might do something, but we find that it really doesn't do very much. So certainly, the visit and the discussion and the conversation around that we have with physicians, nurse practitioners, and pharmacists in the province helps to increase the chances that that information will get used and that prescribing can be adjusted. This is what an academic detailing session might look like. A lot of them are one-on-one, and that's kind of what we ideally pursue. Some of them might be groups of 2 or 3 or small groups. And then, of course, there'll be some added sessions for larger groups, conferences, etc. But it is a discussion, it's engaging, it's interactive, and it can focus on just the areas that are of value and of importance to this particular individual. In terms of the type of information we provide, it would be objective and balanced. That's what we would pursue. Evidence-informed. So as much evidence as is out there, we try to bring to the decision-making table and say, hey, how does this relate to this particular patient decision? It's often comparative. We often have choices, in this case of antibiotics, to choose from. And we also think just through practicalities. So somebody might say, well, I don't know if my patient is going to take that 4 times a day. And we might say, well, that's a valid consideration for some patients. And it all depends. So those type of things come into the discussion, and they're all very valuable and relevant. Our audience, I already mentioned, is primary care prescribers, other specialists, pharmacists, nurses, depending on the topic. And we do a bit of social marketing to patients and public for some topics, and not an awful lot, but for the antimicrobial ABX topic that we did a fair bit of some of this. Let's just list some of the family physicians, the nurse practitioners, pharmacists, the various activities that we did. I won't go into detail on that, but I'll move into overall what we tried to do around the antimicrobial stewardship topics. We conducted 2 sessions, put out a couple of newsletters, did some charts on a few of the main things, some of the common infections. Our ABX1 topic and discussions looked at acute bronchitis, community-acquired pneumonia, pharyngitis, acute sinusitis, and looked at some of the prescribing decisions that relate to those particular areas. And of course, for those, a lot of that is viral in origin, and a lot of the decision-making or discussion involves, how do you manage patients or patient pressure around this? When do you need to use an antibiotic, and which one should you use if you have to go there? How do you have those conversations? The second topic that we took on was a combination of 2, and it was the uncomplicated cystitis and skin and soft tissue infections. And a particular area of interest here was beta-lactam allergy. Because for a lot of those skin infections, if you're not going after the MRSA, you might be thinking of using a beta-lactam, and if a lot of people have a beta-lactam allergy, do you really have to go to something else, especially when it's usually not as effective, according to our antibiogram data? So a lot of practical discussions with physicians and nurse practitioners was had around that particular topic area. At the patient and public level, we did a few things. You can see the bus there. Who saw the bus ad? Anybody see the bus ad? A few people? Okay. So in Regina and Saskatoon, we had a little bit of a bus ad that said, well, if you've gone viral, as in a cold is viral, and a number of those things, then maybe you can skip the antibiotic. And that resulted in a bit of a radio interview together with Justin and Shaquille, who spoke earlier here. And we also did some patient posters, some clinic posters. Those also went onto some of the TV screens that do some social marketing type of things in clinics. And working together with the Regina Qu'Appelle health region, who's represented here, we adapted their viral prescription for kind of use within other areas of the province, and acknowledged their input there. And we had it translated as well into 13 different languages that were requested to be high priority in terms of some of the walk-in clinics that were around. I do have samples of some of our posters at the back, so if you do want to take a look at some or even grab some, whatever's there, you're welcome to take. You're welcome to take a look at those. They were designed to try to allow people to get a little bit of insight on what the doctor might want to talk to them about if the doctor didn't want to prescribe an antibiotic. I already mentioned the TV screen, so I'll move on to one physician's story. And this was an interesting phone call that I had from one of our family physicians who said that her colleague had let her know that somebody had been into the clinic, they had not gotten an antibiotic, they went home. One of their family members, I believe their father, said, "You didn't get an antibiotic," and he was just ripped. So he went back in the next day and he was going to tear a strip off whoever was the prescriber who did not prescribe an antibiotic. While he was sitting in the waiting room, he read one of those posters. And he already kind of let the receptionist have it. And by the time he went in to see the physician that he had asked to see, he actually apologized and said, "Well, I can see why you didn't prescribe." So that's a true story, and I can put you in contact with the person who told me that if you desire. In terms of our service, this is our team spread a little bit across Saskatchewan in a few of the communities, and providing some of those visits and educational outreach services. Just a few ways you can access our printed and digital information. Certainly online in book format. I have one of our books at the back, and then digitally online or through the RxFiles app. The ABX specific is on a special part of our website with rxfiles.ca/ABX. Would be the quick access for that. And with that, I'll just say it's all in the detail. Welcome questions later on. Thank you.
Now I've got to do the setup for myself. Okay, coordinating an antimicrobial stewardship and program in the RQHR in 10 minutes or less. So my name is Robert Parker. I am the program manager for the Regina Qu'Appelle Health Region's Antimicrobial Stewardship Program. My objectives here for my presentation, I wanted to really help everybody to understand sort of what an antimicrobial stewardship program. We've heard that what an antimicrobial stewardship maybe better can be. What strategies, some things that we've done, that we've developed to help organize our program, and always encouraging to be innovative around resources and project management. So no matter what presentation we go into with whatever group that we're engaging with, we always begin with this slide. We feel that it's so important to always introduce our core team. So our core team, we had the fortune of being able to do a project, an improvement project around this, and really look at not only sort of what the guidelines were with antimicrobial stewardship programs, what are the must-dos, but what things did we feel that our program could benefit from. So we had the program manager position, and that's really resourcing, networking, helping to project manage interventions that are going on, and supporting the team in any barriers or obstacles that they come up against. We have the privilege of having Dr. Jason Van Stone. We just call him Jason. He's really fun. Our research scientist. One of the things we started off with our program was having a research analyst position, and that was one of the very first positions that we started with when we started developing our antimicrobial stewardship program. We felt that it was really important to have that baseline data ready for our physician and our pharmacist when they started. We didn't want them standing around, you know, how do we pull data, so we really took some time to develop and understand the systems that we use. We've heard about data management, that it's a problem everywhere we go, and it's, you know, any problem can be overcome. We just need to learn and understand how those functions work. Dr. Casey Phillips as our pharmacist lead for the program. And again, Casey's been great in really establishing what that role as the pharmacist lead can be within the program, and how we collaborate within our acute care and how we collaborate with our community members. We have a 0.5 infectious disease physician co-lead position. We've been unable to fill that, so we've been innovative around how we manage that need for ID input, and we actually have an interim contract, an agreement with our 3 infectious disease specialists in Regina, which is actually working quite well for us. We're still recruiting, so if anybody's looking for a job, meet me in the back corner. We'll see what we can do, but again, it's ways of being innovative, meeting the challenges and trying to overcome them. So we've established clearly throughout the day what an antimicrobial stewardship program is. We know it's about efforts among, and I'll reiterate, among all healthcare professionals to promote all of that, you know, good patient outcomes in reducing the burden of antimicrobial resistance. And, you know, antimicrobial stewardship involves everybody, the patient, patient's family members, current healthcare workers, support staff, all of the other levels of government, stakeholders. We have to have all of those people at the table when we're making some decisions around what we do within our region and within our province. And antimicrobial stewardship occurs not only in our acute care centers, but also in our community, and we have to find ways to be innovative around producing results and engaging with our physicians so that they see success as well out in community settings. Antimicrobial stewardship programs, we discovered early on that there is common thinking, not only nationally, internationally, globally. It's not a one-size-fits-all. There are key components to an antimicrobial stewardship program, but it's so important to look at what your organization, your hospital, your clinic, your school, your network needs in order to make that antimicrobial stewardship program work for the work that you're trying to support. How did we get started? So we started just like everybody else. I was brought into this, promotion of a program back in late summer. Well, there was a meeting prior to summer, then everybody went on holidays. But in 2015, we met again in the fall, and then we were making plans around how, because like everybody else, we failed accreditation. We were unable to show, the major tests for compliance. And being 20 years veteran in the organization, in multiple positions throughout our health organization, I knew that there was antimicrobial stewardship activities going on. I didn't understand how it is that we could fail this. So really, we began by doing that environmental scan, and what is the great work? A question was asked of me earlier today, so you had to start from scratch, and no, I didn't. It was really actually quite easy. There was so much good work that our Antimicrobial Stewardship Committee, our pharmacy did, infection prevention and control, our microbiologists did with regards to antimicrobial stewardship. Lots was on the side of their desks. Some was dedicated time, but it wasn't a matter of starting from scratch. There's no reason for us to do that. There's enough resources out there that we can share and support each other. And so when we were reevaluated in 2016 in November, we passed, we met all major compliances. Now, that doesn't mean that, okay, we've solved the problem, we're ready, but it just means, okay, now we're ready to start. We have these linkages, we have these networks that we've set up. So this is where I kind of, and I've gotten questions, and well, how did you do this, or how do you engage with the physicians? And I like to call it it's change theory, but the theory of Bob. There's so many different components out there about change theory or intervention, project management, that type of thing, and it's really important to understand, again, the area that you're servicing and what it is. And we really, as a team, came up with sort of three main components: awareness, engagement, and education, and then move to your interventions. So with awareness, we really looked at, what is the level of awareness that we're at? We went around to hospital units and asked nurses, tell me what you do with regards to antimicrobial stewardship. And it's like deer in headlights. Oh my God, it's asking me a question. And, and it's like, okay, well, tell me, what you think it is. Like, be brave, or washing your hands. Well, yes, absolutely, it's about washing your hands. But what do you do when you get a patient from ICU and the patient's microbiology report comes back? Oh, well, that's easy. I take that and I call the pharmacist, or I pull in the doctor and I make the ask list. I said, that's antimicrobial stewardship activity. Oh, well, that's easy. The connectivity of whatever action. So relating the crisis or the process of what we're trying to achieve, the rationale to the work that's being done in that area. We met with a group of home care schedulers. We get called and, can you come do your antimicrobial stewardship presentation? Sure, we can, yeah. So we met with this group, and there was sort of blank looks. It took a little bit of effort for those schedulers of the nurses or care providers going out into home care to see their direct line of sight to the patient and how their actions attributed to good antimicrobial stewardship. But they got it, and they're still getting it. We're still learning about how that collaboration can happen in different ways. But again, it's relating and making that a value to the people, not an ideal. We then move to that engagement and education, and that's really looking at different ways that we can do broad sweeping interventions, things that are easy to champion, viral prescription pads, pamphlet developments, which really then once you've got that awareness, engagement, that level of understanding then we can move to those really pointed interventions, and that's the point that we're at. We're starting to really engage and dive deeper into, specific drug tracking, physician peer-to-peer collaboration around their actual usage and what they're doing. But when we go into an area, we allow them to decide what it is that they want to focus their efforts on around the topics that we present to them. We feel the time well spent. We've spent a lot of our time within the first year and a half of our program engaging not only with physicians in our acute care center, but in our community as well, and understanding the challenges. The statistics are out there. We've heard them. 50 to 80% of prescriptions are prescribed in community, and of those 30 to 50% are inappropriate. However, looking at that upstream effect that we can have with education and understanding, and then down at the bedside, it makes those conversations easier, and for us to be able to understand, is that a life jacket you need, or is it a fire extinguisher? And again, really understanding the area that we're engaging with and customizing our program to meet the needs of that group. So growing our program, really, the heart and soul of antimicrobial stewardship is audit and feedback. If it's prospective audit and feedback on a quarterly basis, but it's providing that data that's meaningful to the physician or the clinician that we're engaging with, and how do we provide that in a respectful amount of time. Using old data is been seen as not valid. It doesn't validate the crisis to them, about them personally, so being able to provide their actual data is really important. So finding ways within acute care to make that audit and feedback meaningful, audit and feedback in our community and our long-term facilities, and then with education and engagement in all areas, as well as in our community, and making sure that our messaging is consistent, no matter if it's a clinician that we're talking to or a family member. Moving forward, again, don't look at that one. So moving forward around developing our antimicrobial stewardship program, we're here today, and I thank you all. I look through my rose-colored glasses because I say, see, we're getting it. So that 2050 target that everybody's gonna die isn't gonna happen. We're pushing that to 2060, 2070. The end is in sight with antimicrobials, but we're gonna save them, and we're gonna save them as long as we possibly can, because otherwise we wouldn't be here in this room and we wouldn't be putting the effort we have. Return on investment, it is about better patient outcomes. It's about Saskatchewan taking its ownership of the worldwide burden. And yep, money can be saved, sure, but I really, really hope that we don't make that our primary focus. Embed your program. So this year I was fortunate enough, I found this cartoon a couple of years ago. I kind of put it out in different facets. And does anybody ever read my emails and that kind of thing? But within the last month, I've gotten this cartoon from different people with different sort of, we're embedded. Like, these are people from different areas that have never had a clue about what antimicrobial stewardship is, and they're emailing us, and they're making that personal relationship with our program. So that, to me, is something that accreditation can come back and say, Saskatchewan, you guys are awesome. You're doing a good job, and you're an example to the rest of Canada. So that's the end of my presentation. So we'll move to questions for the panel. We'll take a few minutes.
Test. Does anyone have a question for Jeff, Loren, or Bob?
Thank you, Jackie. I'm a question about RxFiles, because I just don't understand how it works. Do you come to a doctor's office, or does someone have to pay you to do an academic detailing? Like, how does that work?
Yeah, so we do get a grant to provide the academic detailing for physicians in the province, and it's voluntary on the physician side. So we let them know what our topic is, and then we offer to come and provide a discussion around some of the materials that we've worked up.
And does it include like a patient chart review, all of that?
Not usually.
So how do, okay.
Sometimes they'll try to do that. No, so it would involve going through some of the common questions and challenges that are identified ahead of time that we will deal with in terms of some newsletter discussion, some drug comparison charts that look at what is the way to approach drug therapy in this particular area, and just open to kind of the questions and what is of most need to that particular physician.
Thank you, Loren. And it's an excellent program. I mean, 20 years, and it's made a big change in this province. Any other questions or comments?
Sorry, just testing. There we go. So from the various presentations, a lot of it has been very centered on the hospital, and that's understandable. It's a captive audience. It's easy to sort of implement a program in that sort of superstructure, and it seems as though we're coming to a joint understanding of what the essential mechanics of that program are going to be. And I guess my concern is that we don't necessarily have a parallel understanding about what outpatient stewardship looks like. It seems like various things are happening in various locations. And I thought about asking this question to Dr. Saxinger, because I'm pretty sure she runs Do Bugs Need Drugs? But I guess, do you see any, what do you see, if you had to take a tabular approach to this, what would be the essential functions of an outpatient stewardship program, and what might be the scale of the resources required to accomplish it? Sorry.
Well, is this one on? Okay. That's a really good question. I know within the RQHR we have set out to engage with our community clinics within the RQHR, physicians with privileges, without privileges, but within the boundaries of the RQHR, and not only in our urban center, but also our rural facilities, because there's lots of times when our rural facilities will send us a message and say, hey, don't forget about us. You know, we provide patient care as well, and that's very true. So we've made efforts about going out and engaging. One of the projects that we have going right now is called our G12 project, and it's a group of 12 clinics that we've engaged with and that we are engaging with. It's a matter of connecting with them and providing some sort of feedback. They need to have that picture. They need to see that they're included, that they've got resources, and that their concerns or obstacles and barriers have uptake as well. We've heard loud and clear from that there's a big difference with regards to care out in rural versus care in like a community setting. There's more availability to have, you know, a change in a prescription delivered to a resident in an urban center, whereas if you're on a farm or something like that, that opportunity is not there. So that physician who's making those decisions needs to have resources on hand, on the ready, be able to make those decisions and know that they're supported, that they're not out there alone. So by engaging with this group of 12, what we hope to do is really establish, again, we've got 4 urban clinics that we're working with and 8 rural clinics that we're working with in our primary healthcare network, and understanding what obstacles and barriers they're running up to, because we can't solve or mitigate their problems unless we let them have input, and it would be pointless for us to try to just, you know, say this is what you should do out in rural without having that picture. So number one, and that itself will be a slow-moving dial that we need to engage with. But again, when we look at that statistic of, you know, upwards of 70% of antimicrobial prescriptions are written in community, 30 to 50% of those are deemed inappropriate. Let's prove that statistic wrong. Let's do some direct patient or physician prescribing review and feed that back, and then have those collegial conversations with those clinical partners, and, you know, help to make their resources available and more at the ready for them that suit their needs. So lots of resources. Research is a huge component to the work that we do in the RQHR. We tap not only on our or Jason is a full-time employee for the Antimicrobial and Clinical Stewardship Program. And so we also tap on our research and performance department to help with some of those analytics that we do. And so that in itself, and then the ability to deliver the message and what's the right format to do that. So, and that helps, or?
Thank you. Oh.
Hi, I'm Erin. I come from a rural community as well, so this is more directed at you, Dr. Irvine. When you're talking about providing antibiotic usage for your physicians, is that a community prescribing usage or is it hospital, and how do you obtain that data?
So we have the availability of EMR data, which is quite nice, and we do that through the community. We haven't worked on too much because our antimicrobial stewardship program is just, I think, in its second year of existence now, so we're just focusing on hospital work at the moment. But that's something that we're hoping to focus on a little bit more in the future too, just get more individualized data that way too. So that's something that we envision using, and using that electronic medical record is going to be so useful, so much more quick than individual charts sometimes that way too. So.
Any other questions or comments? Should we move over to the interview panel? And so I'll invite Andrea and Paul and Lynora up. And just while we're switching out, I'll comment that not only are we like an amazingly diverse interprofessional group, but our age range knocks it out of the park.
So I'm not really sure. I got a high chair. Maybe that's because I'm vertically challenged. I don't know. So we'll maybe just start the interview panel again. We'll open up questions, allow any kind of discussion that, thoughts that have been triggered throughout the day around antimicrobial stewardship program planning, that type of thing. But you had something that you wanted to share with regards to community. So I'll just let you start off, and then we'll kind of go just organically through the presentations and people's thoughts and engagement.
So I think the community stewardship piece is massive, obviously. So it was a very good question. And I think one of the reasons it doesn't come up as often is because those of us who are trying to do acute care stewardship are like, man, we've got lots to do in this domain. And then beyond, you're looking out at this massive thorny knot of community stewardship. And one thing that strikes me in terms of things that probably have promise and are actually doable would be really looking critically at what resources you have to do essentially audit and feedback to individual physicians based on prescribing data. Because, for example, my College of Physicians and Surgeons just sent me my report card for my opiate patients. You probably have a similar program here. So I got a report card on how many patients I have on opiate and how their daily dose is compared to other people's patients. And that actually, as has already been said by other physicians in the group, you pay attention to that. And it is a very powerful thing because it makes you reflect on your practice in a very granular way. And there was a pilot in BC where they were able to use prescribing data on antimicrobials and give individual primary care doctors, like, this is how much, whatever, amoxicillin you prescribed or levofloxacin you prescribed compared to your peer group. And then coupled that, not necessarily telling them whether they did it right or wrong, they just said, this is how much you use compared to your group. But coupled that with I think they had information about optimum use of those agents with it. And so somehow internalizing your own data compared to others' data and actually being provided with that, some information on, you know, what the optimal pattern might look like, actually seemed very promising and as a system approach, potentially feasible. So it depends on what data you can get and what kind of feedback you already have physicians receiving. But that's one thing that strikes me as being something I'd like to explore. It becomes a bit of an issue as to what jurisdiction that should be within. And so that's why you also have this, you know, kind of frightening opportunity coming up with the amalgamation of health regions, that you could actually really have a critical think about what the governance structure should look like for stewardship, make sure all the right people are involved in that structure, and that would then come to that group when you're talking about how you might implement such a thing. And it would give you a lot more, I think, control about, I guess, the boundaries of what you need to talk about and what kind of things you might want to do in the future. So you do have a real opportunity here. Our becoming one health region was not super well planned in advance, and it was kind of like a capricious decision that then reverberated for quite a long time, and there was some minor backtracking and circling within it. And so it took us a while to kind of start getting a hold of what the actual benefits of a single region are. But I think that is clearly one of them, is that you can have that kind of conversation. And there are some real opportunities there.
That's really interesting that you, when you talk about report cards and that kind of thing, if I can just kind of jump back to that a little bit. So in Alberta, I guess one of the things that we've done with, especially like our G12, our pediatric group, a couple of the other different areas, we pull that data, we de-identify it, we give the physicians a letter. Every time we meet with them, we change the letter just for that, you know, promotion, that the fact that we're not there to police, we're not there to remove prescribing autonomy, we're not there for shaming. So the thing that most clinicians will say to us when we're prescribers, when we're talking to them, is like, you know, the high level detail. This is what you're prescribing. Of course, we kind of ask people, do you have a favorite antibiotic that you prescribe? Nobody does, but when you look at the pie graphs, you know, there's something. So one, we provide the information out on the table for them to be able to have that collegial conversation. We show the data. A lot of them have talked about, and you know, it is kind of policy out there, it's the expectation that you write orders with indication, and measuring the amount of time that we could save, you know, physician to pharmacist, pharmacist to patient, if we had that orders with indication. Is orders with indication something that Alberta's focused efforts on, or is it a nice idea?
It's something I've been interested in pursuing, and I mean, even if you look at the CDC stuff, it's one of the things that they want everyone to have. You should have like the reason for prescribing, the dose duration, the 60s. We have not made it, I think, an institutional or priority, probably because of competing concerns, not because of lack of interest. And actually, in my sort of, you know, somewhere between front burner and back burner, it's in there somewhere, because I actually do think that that helps a great deal in communication. And also, as I mentioned in my presentation, if you actually commit to what you think the patient has, if you say, I think this person has acute bronchitis, that actually changes the conversation in your head, because the prescribing rate of antibiotics in acute bronchitis should be 0. And so actually naming it should make people less likely to feel pressured to prescribe for it. And so that is something that could be both an inpatient and outpatient kind of practice change. And I think that in terms of, you know, potentially useful low-hanging fruit, that idea does have some merit as well.
I think it would really show some benefit and leadership on the part of the clinician, the prescriber, to do that, to write that order with indication, and, you know, without, you know, it's the expectation, CDC's recommendation, but to actually see it. So just kind of off the cuff, so do you do that?
Do I do that? Yeah. I do.
Good.
Personally. But of course I do a lot of other weird things, like I actually put the time when I wrote the order and other things like that too, so.
And that's awesome. One of the things we did comparative in the RQHR as well is we looked at where in the chart, you know, how much mining is necessary, and that's why that orders with indication can be so important. One of the interesting conversations that we were actually fortunate enough to be able to have with Paul and Andrea last night was around the number of orders that we see that have nothing, no matter where you look in the chart. And I guess for you guys out in Nova Scotia, orders with indication, is that something that you guys see, or is it something that you're going to work towards?
So when we did our chart audit looking at our IV to PO step down, we also looked at what the antibiotic was, if there was a duration or reassessment date, and if there was an indication. So we found between 70 to 80% had an indication, and in that case we were allowing them to look anywhere in the chart, progress notes, physician's orders, and people were like, well, and about 40 to 50% had a duration or a reassessment date. So we kind of get stuck on that number being low and think we have to focus there. But I looked at it and said, that means 20 to 30% of our patients are on antibiotics and nobody knows why. And to me, that's a big problem. So it is something we've identified, but we haven't decided how we're necessarily going to tackle that next.
Yeah, and on the outpatient front, right, we haven't done much yet, but I mean, just indication there is even, much, much worse, right? Because, how many scripts do family docs or specialists write actually of what the indication you're treating for? So that's, again, one small nudge in the direction of appropriateness that we've been talking about.
I just had a thought. Because as Paul is saying that, the only time that physicians will write indications for antibiotics is when they're trying to get a restricted antibiotic covered by pharmacare. So in Nova Scotia, pharmacare pays for medications for the over 65 and those that have social assistance and that type of thing. So maybe it might be useful to work with them, with pharmacare, that any antibiotic would require an indication or you're not going to get paid. It kind of puts the onus on the pharmacy, but the pharmacy is going to call the physician and they hate to get bugged. I don't know, it might be a starting spot out in the community to work with those billing agencies to require that.
That's definitely, and again, an innovative way to look at, how to meet or exceed the expectation of how we can tackle this matter and share and encourage physicians. If it's not a matter of just saying, can you please write the order with indication? This way we can tell you not only what you're prescribing, how often you're prescribing, but why you're prescribing, and imagine what the collegial conversations could be around the table if we could do that and show, as we get into cold and flu season, that type of thing. Jackie, from your vantage point where you are, what comments would you have for this type of topic around community? What kind of things are we seeing, nationally around efforts that are being made and ways to engage with physicians, or, those starting points with changing practice behaviors?
Well, certainly the whole indication of use has been a huge discussion because of the number of prescriptions that are written in this country, and majority of them, we don't have that data. So if you think about that, that's a lot of lost data that can help us determine, well, what is being brought to bear in that clinical decision. So we've had conversations with the colleges, not a lot of uptake. When you talk about antibiotics or antimicrobials writ large, there seems to be a bit of a reluctance there to go there. As well, just from where I sit, we've had chats with Health Canada about, well, you're regulating use in animals. Have you thought about regulating use in humans? Nobody wants to have that discussion either. Yet. So I think we need the data in order to know whether or not we should be restricting more access. So how do we get there? Because we've got privacy laws, especially if it's a community prescription that goes to the pharmacy, all kinds of things. So I don't have an answer to that. I mean, I certainly have ideas, but I'm not, I don't think we're there yet.
Thanks. At any time too, I want to encourage the audience to feel like, jump in with a question that you have. If there's something that happened throughout the day that you'd have something to talk about, do we have a?
We do have a
do?
question
Okay,
from the
sure,
floor.
Go ahead.
Hi, Sherry with Infection Control in Saskatoon, long-term care. And my question is around the community antibiotics. We know that our largest portion of antibiotic use is in the community. And anecdotally, we've seen a lot of ESBL, particularly in the Saskatoon health region and also in our long-term care settings. So I guess 2 questions. Is that long-term care data able to be extracted from the community data where it's just a community lump? Because for our long-term care homes, our prescriptions go to the community pharmacies, so they're not necessarily flagged as being long-term care, but I know that I go in and look and see who's on antibiotics sometimes. And so then secondly to that, is there a strategy for long-term care AMR? So, yeah. Anyone can answer.
Well, I know in Saskatchewan, in the RQ, depending on, like we've recently made an agreement with the drug plan around de-identified information. It was a bit of a task in the making, getting to that point because of privacy sharing, that type of thing. If it's a facility that's owned or is an associate with the health region, then we have access to that information if it's within the borders. There's other avenues as well as having agreements with physicians. So in some of our other long-term care facilities, we work off of medical records like MedAccess or Accuro. So the RQHR owns MedAccess, but we don't own Accuro. So therefore we have to ask the physicians for permission to pull and aggregate their data in order to feed it back. But again, those are those initial conversations. Is there a plan? They definitely need to be in the circle conversation. There's constant movement from patients in long-term care into our emergency departments for things that can be treated in the long-term care facilities. So why would we not look at that? I might turn to Jason, who's our research scientist, and ways that we can collect data. What are the barriers, challenges? I think as we go forward, we're going to see sort of lumps and bumps in the road, but just to recognize them as the lumps and bumps. I know one of the bumps that we experienced within the RQ, when we went from our innovation system to SCM, we lost our patient days. So it's just a matter of figuring out how we pull our patient days from that system and then, or what do we need to sort of mitigate that. But Jason, do you have anything else that you would add to that matter of round?
I lost your specific question again. What was that?
Community.
We have the community data for how much antibiotic usage is there. Is there a way to pull that data out? I guess I'm thinking
For long-term.
on the national level, because we have that, we have the national
We haven't.
surveillance data that we've done,
Yeah.
and then have we pulled out to say this is how much long-term care usage?
That would, yeah.
Yeah, I can respond to that. No, at this point, we cannot pull it out. And that's one thing that the CARS, the Canadian Antimicrobial Resistance Surveillance System, is trying to tease out. And so we've just done a point prevalence study with partnering with IPAC Canada, specifically looking at long-term care facilities, because we do want to get a better picture of what is the magnitude, of resistance to what, and then what is the antimicrobial use going on. So we're hoping by our next November report, we will have a better understanding of that. But right now, the prescribing data that we have access to doesn't give us that level of granularity.
I actually have a question, which is, we're talking about utilization in a specific subset of patients at high risk. And at high risk of both bad outcomes from antibiotics and inappropriate antibiotic use. And I know some of our labs actually pull out long-term care data separately, so you can get like a urinary tract isolate antibiogram from long-term care from some of the labs in Alberta, and it's shocking, like it's horrible. The resistance rates are just astronomical. And so my one comment would be that it's always a yin-yang thing. If you want to get utilization, you also want to get resistance. And so having that conversation about what can we look at in terms of the antibiogram data for this particular patient group becomes very, very useful. And it often is doable as long as the labs know what you're looking for. And I'm looking now at Jesse to see if they're doing this already or not. But I think in Calgary that they actually have long-term care pulled out for their urinary tract isolate antibiogram. And that's where I saw some completely hair-raising data that freaked me out utterly about both ESBLs and quinolin resistance. So, you know, anytime you look, you find, which is the problem, but you have to look for both the utilization and the resistance.
It is basically an IT issue of how things get coded in the lab system for what data we can pull out. And so this last year, 2016, was the first year in our QHR that we were able to specifically get long-term care data. I think Saskatoon has had it routinely for a couple of years, and it's horrifying. Yeah. It's bad.
Okay. Oh,
Yeah, nothing really to add except that I agree there's some shocking results that you kind of go, ooh, I don't know if I wanted to see that in the first place. I just wanted to bring it back in terms of comment around utilization that and indication-specific utilization that I caution around just centering totally on indication being on the prescription, mostly from the perspective that I think it takes us down a bit of a diagnostic rabbit hole where, especially in things like highly relevant populations like the elderly, where you can necessarily put a diagnosis of UTI without actual comprehension of is it asymptomatic versus just a positive bacteria. And in the long-term care situation, especially where you have a physician who may or may not be attending to that actual patient, as is the case in Saskatoon, you have nothing but a nurse with a positive urinary culture and the absence, and then therefore writing a prescription that says diagnosis UTI. So while we have a diagnosis and an indication, we've also created a situation of improper utilization going one step back. So I think it's an appropriate thing to look at in terms of writing down the diagnosis, but I don't want, I know that the panelists and myself are not hanging our hat just on that.
We don't actually want to believe that diagnosis necessarily, but at least you actually know what domain they think they're treating, which is a starting place. So it would allow you an opportunity to start with some audit as to whether or not the patient has symptoms, for example.
And if I can jump in there, I think from my perspective at the national level, what we see at other countries trying to reach targets where they're reducing antimicrobial use by 20% or 25%, that worries me because I don't want to see that we do this systemic, we're just going to stop everybody using antibiotics when in fact sometimes we need to ramp up our use of antibiotics if it's appropriate. So how do we then unpack that about appropriate antimicrobial use? Because that's what we want to trigger. We want to make sure that those antimicrobials that are being prescribed appropriately. And so I know many countries are establishing targets. Canada's been asked to establish these kinds of targets, and that's what worries me, is that we don't have enough data to do that right.
so, good. Again, capitalizing on that topic of data, there were OECD estimates published, I think, just last week, and Canada contributed to those estimates, and we were, as you'd expect, probably middle of the pack, just above the OECD average. But when I looked at the little star next to the Canada, it says, oh, well, there are only 3 provinces reporting into this average, and they are Manitoba, Saskatchewan, and British Columbia. Part of the reason why this is so complex is because there are so many different players calculating usage in so many different ways and reporting them to various extents. So I guess this might be a question for Jackie, and it's a 2-parter. One is, has there ever been a mapping exercise, or is there some document sitting in a bottom drawer somewhere that gives some idea of who is collecting what and making that available to what extent? And the second part of that is there a prospect for bringing a little bit more clarity to that using more unified metrics?
All very good questions, Charlie. You can buy me a drink and I can talk about Kai. That's another conversation. And because the data that they used for that particular study or that report is incomplete. So we have a bit of an issue with that. But fundamentally, the whole creation of the CARS, which I've been talking about several times, the integrated surveillance system that Public Health Agency has done, is to try to map what data does exist and can it fill in the picture. We're only in year 3. This is our 3rd report, so we're still in its infancy. A lot of it stems on the fact that there's still a lot of gaps in the data, and the data that people are accessing, such as hospital discharge data, is really woefully inadequate. And can give you a marker, but it shouldn't be something that creates headlines. Anyway, that's for another day. But the fact is that the Public Health Agency is to do that kind of mapping to figure out, well, who's got data? Can it help fill in the storyline? And are there other people who are willing to gather more data and the right kind of stuff to ensure that, okay, well, if we're going to then implement interventions that we call best practices, then we better make sure that they're best practices.
One additional comment on reports and drawers that might be useful was one that I was one of the co-PIs on from the NCCID. In what year was that? Anyone? 2014, 15? And it was surveillance of AMR at AMU in Canada. Yeah, that one. Oh, it's not in a drawer. That's actually out. Oh my goodness! Yay! Look there. The recommendations aren't actually in the document though, because there was a little bit of politics happening at the time it came out. Which was extraordinarily weird. And so the recommendations are actually on the AMI Canada website, and now I can't find them because they've moved something. So if you need the recommendations, you have to email me apparently, and I'll get them to put them back on the website. But it did actually go through, basically what is being collected where, and it does try to deal with some of the FPT concerns that come up when we're trying to get a system across Canada, because I'm sure it's like herding cats, honestly. I have no idea how you guys do it. But it does actually go into, what do we know about resistance? What are actually truly transnational resistance things that are being followed, and what are the biggest gaps? And in my mind, an opportunity that's also a gap is antibiogram data and community-based resistance evolution, which is really, I think, where all the action is from the point of view of stewardship. That's what we want to know, and that's what we don't have a national picture of presently. I know there's work going on in that regard, but to me, that's something that, as you are sensibly aligning yourselves in Saskatchewan as you build a system, thinking about how you can use your antibiogram data to inform knowledge of community antimicrobial resistance development over time, you could actually become a leader in the country too.
I was wondering, so a lot of people have talked today about the makeup of an antimicrobial stewardship program. So we've got our physicians, we've got our pharmacists, and there's a lot of great work that comes from that. We see, the literature is filled with data. We've done this intervention, we've done this intervention. We see drops in antimicrobial use or whatever the case might be. But invariably those, if you follow those studies out, as soon as they're done, you look 6 months later, a year later, and levels start to go back because humans are creatures of habit, and so we go back to our old ways. So my question then, and I'd like to know what each of you think about this, is there room or is it time to expand that definition of antimicrobial stewardship program, the members, to include people in the realms of psychology and social science and people who are experts in behavior change and change management, as most people who are parts of stewardship programs currently are not necessarily, don't necessarily have that background?
I can take a first crack at that, because absolutely. One thing that we know is that if you do a stewardship project and you walk away, the regression to the mean happens. And so that's why stewardship programs exist, because the program is people who are there all the time, and you keep on poking, and you keep on poking, and you don't go away, because if you go away, everything swings back to the middle. And so, if we had some magic way to actually create changes in practice that were sustained, we'd be able to get a lot more done because you could go to a place where you identify a priority, you could address the priority, you could leave, and it would be fixed. And so, yes, if you know anyone who can do that, by all means, I'll try to find something to hire them in Alberta because it is a real problem. And lasting change is very difficult. How do you make it stick? And we're not experts in that. There are experts in knowledge translation and change management, and I think starting to liaise with people with that expertise is very useful. And in the meantime, we can't leave because if we do, the work is undone.
Yeah, and I mean, I echo that. I mean, certainly in Nova Scotia, we don't have such a person yet. We kind of started looking, but definitely on our wanted list. Not only, making our initiatives stick, but designing initiatives that will be effective, right? So, using, theoretic domains framework, things like that to design a framework or design an intervention, but also understand why that intervention was successful so you can replicate it and make it scalable, right? So the classic example, or one example would be surgical checklists, to, make sure prophylaxis is given correctly. WHO did some work, it looks like a great thing, and then they rolled it out all across Ontario, and it did make a difference on outcomes. And why is that? Because, they just said, you have to do this checklist. They didn't understand what was it behind that checklist that made it useful in some centers, not other places. So not only in making our intervention stick long-term, but also, making good interventions in the first place is super valuable to have that behavioral scientist on your team. So definitely a valuable resource, but hard to find, I think, certainly for us.
I would echo the comments of the two previous speakers. I would also say that, there's a lot of research been done about behavior change theory and what it takes to sustain a behavior. I think part of it is we need to start people young while they're still in training so that their core, their median, their go-to place is in a better place than where we are right now. I think that's part of it. And I think there's a lot of things we can be doing that I know federally we're looking at in terms of nudge theory, where you get people on the road to making a concerted change, and that it's motivated internally, and that's the big difference. It's the external motivation is not something that can be sustained over the long term.
I don't have a whole lot to add to that other than I think one of the questions Bob had said to be able to think about is what, if people ask you, what do you do? How do you explain? And when somebody's to ask me what my job is, and the short answer to it is I'm trying to create culture change. And the one piece about that is I think data shows that to really get culture change to happen, it's 7 to 8 years of actually, so I'm in for the long haul. And that will be, what we're starting now. If we keep at it, we might actually see being uptaked continuously in like 7 years.
I think you made an excellent point, and I think in relationship to almost everything that everybody's talked about here, behavior change, the way we accept and see the work that we do, the sustainability of the projects that we engage with. One of the things that's sort of gone through my mind is really, and it has to do with the data management as well, like the places that we collect the data from, whether it's our IT resource or it's the drug plan or it's pulling data from other sources. As soon as we say a quality improvement project or changing behavior, it's a project, to me it has that beginning and an end, and that just changes the conversation. I've really believed that, and the conversations that I've had around data management and pull is changing the way we have people see the work that we do. This is not, an improvement project where it's a start and a beginning, and then it's got an end, and then that's it, we walk away. To me, this is continuous daily work, so we need to change that from that quality improvement to that operational. A few times I've used the rationale or sort of an example. It's, data to a clinician is like a Band-Aid to a nurse. You would never tell a nurse to treat a patient's wound with one type of Band-Aid, for the next 3 years, and this is all you're going to get. They're allowed to make those choices. They pull off of the shelf what they need, when they need it, how they need it. And to a clinician, in order to be able to do that job better, we need that availability of resource where we have these data sources that we can go to and pull it off the shelf. I think of an example that we had, and it was around our patient days, and there was a question about a correlation between a drug that was being used and an outbreak that we were seeing in different areas. Because we had that retrospective analysis that we did in our organization for 4 years, we were able to pull that off the shelf and answer a question within 20 minutes, and then just led to next questions and what else do we need to. But how do you feel about changing that perspective with the data sources that we go to collect this data in a timely manner, about changing that perspective, that this is not just a quality improvement project, but it's part of our daily operational work that we need to be supported as clinicians in our prescribing or our patient care?
I'm interested because to me there is some benefit to identifying a certain priority as a project, because then you actually complete the loop, you finish the cycle and you bring it back. And so I think that there's probably a case to be made for kind of structuring stewardship as the ongoing longitudinal work that you think has to be going on all the time. And then maybe possibly looking at some intermittent, honestly, this is going to be a project because you can't sustain everything all the time. That would also be informative. So I'm actually kind of the mind that there might be a reason to say that there's a blend, and that some of the work really might be a quality improvement project, and other work actually becomes part of the everyday longitudinal stewardship business. And that you might end up doing some longitudinal stewardship based on your institutional priorities. Like if you have the resources to do restricted antimicrobial audit and feedback, boom, that's what you're going to do in your institution. And then you might have a reason to intermittently look at things like surgical prophylaxis, whether it's appropriate. Is this a problem? We do a QI project. We decide whether this is something that we have to continue doing, or we decide that we're going to come back and do another project in a period of time. So I think in truth, there probably is both longitudinal and project-based stewardship, and that the same group of people might be doing both at the same time. I think what you're talking about in terms of the data piece, like basically being able to access the information you need to inform your development of priorities as a stewardship program, is incredibly important, and thoughtful attention to how we can actually get the information we need to first develop our priority list, and then next start to see if we can actually impact the patterns that we're seeing, is just such a core fundamental thing. And a lot of the time that I spend in stewardship is trying to find out what we know before I can even decide what I think we need to do. And that can be very time consuming. And so if you can get a system set up that makes that process quicker, you'll be much more efficient as you kind of work through different priorities in a stewardship program in either acute care or community or long-term care.
I think I would just add to that as well, building in the concept that it's not just quality improvement, but it's quality healthcare, and stewardship is part of that quality healthcare, as well as patient safety. And really, that tends to get a lot more attention when you start talking about it in terms of patient safety.
Paul, have you ever been frustrated by some obstacles or barriers you faced with trying to retrieve data?
Yeah, I mean, am I on? Okay. Yeah, I mean, that's been, every week so far for us. Luckily, I mean, through our connections or, by reporting directly to our VPs, they've been very supportive on getting us help, human resources to try and fix that when possible. So Meditech, for example, they've been very good actually at listening to our concerns about pulling out DDDs and changing it in, somewhat, real time or, as quickly as possible. So there's been good movement that way. And, I guess having that connection with VPs has been helpful in that regard. Otherwise, a lot of it's been folks coming to us with their issues for surgical prophylaxis. Talked a little bit about that earlier, but the anesthesiologist recognizing or anecdotally thinking, well, we're using a heck of a lot of Clinda, probably for folks who don't have a true beta-lactam allergy. So then they're able to pull data for us. They have access, to their data and data analysts. So using those resources that are out there, not trying to reinvent the wheel every time, but letting folks bring data to us too, and working with them to make change with their data, has driven a lot of our early work here.
Hi, my name is Rashad Hensia. I'm a family physician in Regina, and I also work for the primary health care part of the Regional Health Authority. So I just want to go back to the question that Jason had earlier on, which was around how do you make it sustainable? When do you introduce behavioral theorists? When do you sort of do those kinds of things? So I've had the opportunity and the privilege to witness some of the work in Regina as it unfolded over the last few years. And I just want to add a few comments, which I hope will spark some thought. I think all of this, everyone has sort of alluded to in the presentations today, and also in some of the answers, it's come through, but no one's actually spat it out in the way that I intend to. So I think when you're looking at this behavioral change type of intervention, you can either do something to someone, or you can do it with them. And so I think what I've observed in Regina that has been really powerful is that a lot of, like this team that spoke up there from Regina came to every departmental meeting, spoke to physicians, shared information, showed some data, and took people along this journey. So it wasn't a case of we're here to fix a problem which includes you. It was a case of we are here facing a common problem, and so we together can find a solution that's sustainable. And I think that's the way to get around this regression to the mean once the intervention slows down a little bit, which is inevitable. So I think if you do it with that and you actually make those physicians or those clinicians or prescribers the change champions, as time goes by, they will continue to teach their colleagues and new people coming in. So I just want to share that perspective. Thanks.
Hi, my name is Marina. I'm a pharmacist. I work up north. And so a while ago, we embarked on our Antimicrobial Stewardship program, and the first thing we thought is, well, we have to figure out where we are. This sounds so simple, and yet you've all alluded to this part about data sources. So we figured out, well, we were doing a retrospective cohort design study, so we needed length of stay, unique identifiers, readmission rates, ICD codes, and then we started looking at, okay, in Saskatchewan, where does all of this data live? Well, our pharmacy system, I'm the only pharmacist up north, so our system is not up to date for every patient that comes in. We have an EMR for physicians, that's kind of used in the hospital, but not. We have information that goes to the ministry from the DAD, which I think is the Discharge Abstract Database, if I'm correct. Some of that feeds into CIHI, and charts, of course, which, who wants to go through hundreds of charts to figure out where you are? And so this brought to light a bigger question of, okay, data sources, where is the data? Where should it be? How are we going to get it? If we're going pan-Canadian, should it be CIHI? And perhaps the people from Nova Scotia, since you're a little further on your journey, where have you had to go for information? What kind of, as we're moving towards one health authority, what would you put out that we consider? And one last question on top of that is there anybody from eHealth or that? Yeah, because it would be nice to have eHealth involved, because we have to figure out what data we need, what databases exist, whether they should be provincial or tied into CIHI. So
fingers crossed. I'm going to go out to WebEx because I do believe I have some eHealth and I have some Health Quality Council partners on WebEx. So if there is comments or suggestions or information that can be shared out in WebEx, send your chat in. If not, we can connect. I know we've looked at, and Jason probably is the best person to comment on that because he's done a lot of work with engagement outside of the RQ. So again, probably similarly, we're working with BDM in our pharmacy department in our facilities. Our rural facilities typically don't use that, or it's a community pharmacy, so it's all paper-based. Meet the challenges where they're at, and what do we have? Like, where's the first place you can start is really essentially what we looked at. But Jason, did you have anything that you wanted to, in your conversations with eHealth, I just know there's been those restrictions around borders that we have within our province, and again, December 4th for me is going to be like Christmas, because I'm sure as soon as it happens, there's going to be presents under the tree for us. It's just all going to work, but yes.
And
Yes.
I'll just make a comment. Someone from Health Quality Council was going to be there but wasn't able to make it at the last minute. But the point about eHealth as a partner is a really important point. So if someone is still listening and has a comment, then we would welcome it on the chat. But
Data was a giant ocean to try and fish from when I first started, a year and a half ago with the program, and so it was making those little incremental things. So locally, if you've got local things you can look at, that's a great way to start with. If you've got a pharmacy system that you can pull some kind of local data, great. At least you can start sort of boots on the ground. This is what we're doing here. If you want to start comparing broader, so that's where I think Bob mentioned that we made an agreement with the ministry to get some of the data from the drug plan extended benefits branch. So we have some of that data coming in. We've talked with eHealth to see what kind of data they can pull from other systems for some other different resources and things like that we're looking at. And of course, in all of this, the big issue that you're going to come up against is the privacy legislation, because there's who owns that information and how and who they can share it is sort of a big piece of that puzzle. And so it's making your way through that I think is the majority of the barrier. But once you get through that, the information is there, and it's a huge piece that you can have to work with. You then hit the problem of what's my denominator, and I'm going to talk more about that in my meeting tomorrow, or in my talk tomorrow, but finding that baseline of like, okay, now how do I use this to compare, because we need to compare amongst either similar groups of patients or just by numbers of patients or whatever the case might be. So it certainly is a large mountain to climb from the perspective of someone who's been doing it for a year. So
just to follow up, we actually got through the privacy, we got our data from the ministry, and we're stuck with hundreds of chart reviews to do, because that's the only place some of the other information is in. So we got past that, but I think moving forward, it's just, what does our future state look like? Where should we be pulling this from? Because it shouldn't be this hard, and it shouldn't be hundreds of chart reviews. And we do have sample size calculations done, everything, and we have, I think, 600 charts to pull and review in our spare time. And I love bugs and drugs, but 600 charts to pull on my own time. So anyway, but I'm not looking to have my issues solved, but it's more just, what does our future state look like? And
I think that's an excellent question, and I think that's really our purpose tomorrow, that we can really look at some of these things, common denominators, things where we all can come around the table from Saskatchewan to say, I know we have access to some pharmacy in some specific areas, and looking at common threads, and even if it's maybe region to region to region, if we only include 3 areas in one pool and some others in another, but we'll pick a place to start, and let's just start there. But that networking amongst all of the people that are attending tomorrow is just like an excellent first step, and that can be one of the first things on our gap analysis is, where do we start with the data? What should we be looking for? I think maybe we have time for one more question.
yes, and did we get any replies on the chat? No? Okay, last question.
My name is Chantal. I'm a veterinarian. I've transferred over to the human side now. I'm a board-certified clinical pharmacologist. I think we all agree that we need a cultural change. We're sitting here as shift disturbers, and that's really important. But in a culture, it's multifaceted, and there's many disciplines that need to be involved so that change can be sustainable. And we've talked about prescribers and pharmacists, and there's a couple of things that I think perhaps are missing in this AMS process that we're trying to establish. One of them is being, what are we doing to decrease the hospital-acquired infections? A lot of the antibiotics within the hospitals are prescribed to either prevent or treat these hospital-acquired infections, and we need to perhaps bring these people in to find out our processes and establish them within our AMS. And the other thing is something that really stuck with me at the beginning of the day when Lynora talked about physicians wanting to cover their patients. That makes us feel good. And that's great and that's important. So what are we doing to find alternatives to antibiotics so that physicians still have the chance to cover these patients or at least prevent these infections before they even occur, so we can spare our antibiotics and use them for what they're supposed to be used for, treatment, and not so much prevention of infections. So I guess my question is, do you see other disciplines coming in and helping with these antimicrobial stewardship programs to help sustain on a longer term these programs?
Well, I think some of what you're talking about maybe have been kind of alluded to but not really laid out incredibly clearly, but there's lots of people from infection prevention and control in the room, and in some jurisdictions in Canada, antimicrobial stewardship is actually taking place within infection prevention and control. Like, that's the group that's taking it on, that's the group that's adding personnel, and that's the basically, I guess, reporting mechanism for stewardship in some places. Other places are doing stewardship under public health, like in Ontario, PHO is doing some stewardship in some smaller centres. Other places is doing stewardship within pharmacy. Other places are doing stewardship kind of as a standalone. Other places are doing stewardship as quality and safety. So I think that the players are all very well defined, and it's just important that no matter what structure is set up, that you make sure that that very important linkage with your infection prevention and control team, which is also an accreditation standard, and is a very well-structured program in most health systems, is present and there, and that you're working in conjunction directly rather than kind of in isolation in silos. So I think that's like one key thing, and although we didn't necessarily highlight it directly, I think that it is there and it's well acknowledged across stewardship that IPC is your friend and IPC actually might be your stewards in some cases. I think the second part was about people. What was the second part? Alternatives. To me, part of that is there's a couple of technologic assists that are going to end up helping stewards. One of them is going to be rapid diagnostics and point of care diagnostics and helping to define whether something is bacterial or viral more quickly. That will help. We're not quite there. There's some things that are probably pretty close, and in some places, if they're used properly, can be useful, but we're not quite there in most places in Canada to deploy those tools optimally. But rapid diagnostics can help tell people that, no, it really is a virus, and no, you really don't need the antibiotics. So that's one thing that's in the works. And then the other kind of, I guess, technologic help is going to be in antimicrobial, microbiome, phage therapy, outside the box thinking, outside of antibiotics. I think from a stewardship point of view, we like to see this happen, but I don't think I should be doing it because that's not my area of expertise. So although I like to know what's going on and see things are coming, and we have to promote outside the box thinking about alternatives to antibiotics, I don't necessarily consider that core stewardship business. I think it's something that we should be aware of and in tune with, but not necessarily do.
Yeah, and I think just to reiterate things, or other disciplines like nursing, right? So getting Foley's out sooner than later, getting the central lines out quicker. So there's a lot of prevention that can be done there as well. But getting nursing, involved in your core stewardship program is definitely invaluable for sure. Along with patient and their family. So those are two big things that we're working on more in Nova Scotia. Yeah.
Just looking at remember there's 4 pillars when it comes to AMR, so it's not just stewardship, infection prevention and control, research and innovation are 2 other key pillars besides surveillance, of course, but And so industry is coming to the table. They want to be a player, and they want to see where they can help, but also promote their products. So as long as we're very aware of what industry is there to do, which is sell their product and make money for their shareholders, they also have a social conscience. And that's what we're starting, the discussions at the federal level when they come knocking is, where is their interest? How do our interests align? What are the new technologies that they're bringing to the table? New disinfection techniques, new surfaces, cleaning, whatever. Because we do need to understand where is the research going, not only just on the antibiotic front and alternatives, but in terms of infection prevention and control.
Wake up. And that's one of the things I think, being embedded in the Antimicrobial Stewardship Program in our area, we've really looked at those relationships. And again, I go back to like our accreditation score in 2015 to the difference that we had in 2016. And that wouldn't be the way it is without the relationship that we have with our pharmacy department and all the work that they do, our microbiology department and the work that they do, infectious disease, our infection control department, and as well as the nursing relationship, both primary and community, as well as our support staff. And we can't forget about the relationship that we have with our senior leaders, because without those barrier removers, a lot of our work would be at a standstill. So those partnerships are very important. I'd like to thank all of you very much for your engagement and presentations today. Everybody for your active listening and engagement that we've had today. Valerie, I'll turn it over to you to maybe sum up the...
Sure. So we're near the end of the day. I want to start this by acknowledging people who are still in the room and not in the room who were on our planning committee. So that's Bob and Jackie Arthur and Orly. Please stand. Gwen, Jesse, Jeff. Anybody I missed or can't see? Thank you so much. So we could not have Casey back there. I need better glasses. So thank you so much. I mean, this group suggested speakers. And Wendy. I think Wendy left, but Wendy Wilkins from the Ministry of Agriculture. So thank you so much. And Justin and Shaquille. Okay, I think that's everybody. So obviously, many hands make light work, and they were responsible for bringing in, the full range of speakers and topics and suggesting all of that. We were going to, Jackie and I were going to sum up the day and then talk a little bit about tomorrow. And we'd like to thank our 3 out-of-province keynote speakers with a small token from Saskatchewan. And people have been coming up and handing me their little notes pages. So if you have any, feel free to hand them to me or to just keep them on the table and we'll pick them up, whatever is easier for you. Terrific. So we'll come up to the front and do that.
So hopefully we've given you a good taste of the breadth and depth of what's going on elsewhere, what's going on in Saskatchewan, but also what can seed our discussions tomorrow. I want to take the liberty and just kind of pulling out a few things that we should consider for tomorrow's discussion from my perspective. And I think one is about local data. Antibiograms, other information that we're going to need and to think about that. Governance, how are we going to organize ourselves? Who's going to make those decisions? Who needs to be engaged, making sure we have the right people to the table, engaging appropriately and respectfully, knowing where people are at. leverage who else is doing work in this space, as well as this is going to take some time, and so we need to invest in that time, and we need to invest in the training to build the competencies that we're going to need, and ultimately the meaningful communication and trust that we need to build, or that we have already built and we want to expand. So I think I have a few other ones, but I think those are the key ones that I wanted to just plant for you and think about as we go into tomorrow's discussion, and think about how we can do this on a local, provincial, what needs to be local, what can be more system-wide, what can the federal government help support. Like, let's look at it from all angles.
Thank you very much, Jackie. Bob, did we want to do a quick, what we planned to do was send out a survey in the next few days, once you've had a chance to think about it, both about the meeting topics as well as any kinds of, constructive criticism for us, should we do this again. But did we want to do a quick, a few what went well and what could have been better? And would you take some notes if we did that? So what was, and what will help us tomorrow? So what was good and what would be helpful? Sakib?
The big picture is important, the provincial picture is important, the regional, local prevention is important. But then I think in the afternoon, some really good examples of what do providers need to know and how to get them that information in a way that's meaningful and improves patient care and improves your own satisfaction with work. So I think that tied up the discussion in terms of, how to move this forward, I think, very well.
Thank you. Any other immediate comments? And then what could have been better about this meeting? I can take it. Go ahead. Were you warm enough? I heard someone wants cookies instead of, okay, I'm trying to limit my complex carbs. I'm just... Cookies. Okay, got you. We will make that change.
Was the room set up? Will this be conducive for our discussions tomorrow? Does that work?
Actually, we're making a change, and we'll have cookies tomorrow morning. I shouldn't have said that now. I should have said, yes, we listened and we acted. But actually, we had them pre-ordered. Anyway, podium mics. So like a stand-up mic in the audience? Okay, and maybe we could do that for tomorrow. So tomorrow, so let me say, those of you who have to leave today, please travel safely. If you look outside and it's horrible and you decide you want to stay, please come back. We will welcome you. Tomorrow we are expecting a smaller group though, so we were about 80 today and we're expecting 50. So we're going to be, this will move and we'll be in that half of the room, so the display charts will stay, and please have a look at them, but this will be gone. So we'll be closer together, but we might be able to get a floor mic for tomorrow if that comes up. We're starting with breakfast at 8 o'clock, and our agenda with Jesse Minion's presentation about the lab is at 8:45. And we'll provide a break with cookies and a lunch, and we'll be done before 3.
And I have one final, just to thank our audiovisual folks at the back, Marty, Con, and Rob. Thank you very much.
And they were here with us all afternoon yesterday too, so they've made a good effort, although I'm sure they also hung on every word, as we did. But thank you, great job. Okay, well, thank you so much. Take some cheese and fruit with you, and we'll see some of you tomorrow.